45 minutes of learning how to be an amazing teacher in a busy ED. And Josh and I were chatting last year and how we find teaching more and more challenging due to the pressures that we're being put on right now in the emergency room. And we're getting busier. We're seeing a lot more boarding. We're very different hospitals, but facing a lot of the same challenges. And our residents give us the mantra a lot that we're not being taught. So we're trying to find ways to integrate really good teaching into a very busy emergency room, which I think we're all, unless you're in an amazing, if you're not in a busy one, can you come find me afterwards? Let me know how that's going. How you're enjoying your night shifts with 2 patients. I'd like to be there with you. But otherwise, I definitely am finding this challenging. So, and of course I'm from Hopkins, so I have to give you Osler, at least one quote. But he was one of the leaders in developing the bedside teaching and bringing it to the patients. And that's still very important to our learning modules on how to teach our residents and our medical students. So our outline today are the challenges to teaching. We even do a little bit of a literature review for you. And then how to teach in a busy ED. And then I actually have a little section on what the residents say, and then we'll go through our conclusion. And I don't know if anyone ever feels like this when they're trying to write their charts behind their counters. I find myself more of an information person about where the bathroom is and where to get water. And yes, I can get you a warm blanket. And actually we don't have pillows because they tend to, grow legs and walk out of the emergency room. But if I could help you, I would. So does anyone ever get one of these? This is my faculty report card. I call it my love letter. I get it once a month just to remind me of how awesome I am. It has all my metrics on there, just to make me feel really good about myself. They actually sent this to me on my maternity leave just so I could remember how awesome everything was and what I was missing. And it has every single thing in there, my average patient seen per hour, my patient volume. It also ranks me, so I know exactly how much I suck compared to all of my colleagues. And I look at that and I'm just like, how do I change this? And do they put in any kind of caveat that on half these days our NEDOC score, they don't have a NEDOC score, we're on disaster mode. We have over 200 patients in the ER and they're boarding for 48 years and I'm going from helping them with their college planning and on up. And then just to kind of give me more positive vibes, they put my Prescani scores on the bottom. They're all zeros. I'm not sure what that means. So the challenge is often that we face in the metrics, right? We want 4 hours for disposition. You got to figure out what you're doing in 4 hours. We got these little faces next to our patients' names that start frowning at you at 2 hours. And it's like, oh my God, they're turning from orange to red. Then we have putting out fires. Half the time I'm dealing with the fact that we ran out of urinals. Yes, we ran out of those big plastic things that people pee in. We couldn't find any. And then confidence and knowledge has been actually quoted as one of the main reasons faculty do not teach in the emergency room or in medicine in general. Our residents ask a lot of questions. They're great questions. There's always this underlying fear we may not know the answer. And then again, what we're probably a lot of us are facing is how to teach in a limited time frame. I've got to get the patients dispositioned. I've got to get the consults on the line. The consults don't call back. Now it's my job to call the attending. So lots of things going on. So I'm trying to teach and also make sure that the little angry faces don't show up next to my patients' names on the trackboard. The next thing is who teaches the teacher. A lot of our programs do have the senior residents teaching, and we're really trying to put into our curriculum how to teach, but it's actually not part of our core content. It's not an overall universal thing that we teach. How do you teach a pretty intelligent learner, an adult learner, and how do you teach them in the clinical arena? You can all do small groups now, or really good interactive sessions, but how do we do this, and how do we translate that to our senior residents who are now graduating and going on to be junior faculty at other programs? Have I taught them how to take on this role is a big question.
So how do we teach the teacher, and us as grade EM physicians, where do we always look when we need information? We look at the literature. And unfortunately, there's really not a lot of literature about this topic. And I'm going to bring up just a few papers. There really is very little. In case you're wondering, overcrowding is a problem in EDs. This is a paper from 2000 from the Annals. And the reason why I have this paper up here is because one of the first things that this paper quotes as suffering from ED overcrowding is teaching, and all the other things that kind of go along with it. But we have to teach, and if in our overcrowded ED, one of the first things that is suffering is teaching of our residents and students. This is actually from the general medical literature, more about bedside teaching on the wards and how it's in a decline for some of the reasons that Leah pointed out. And I'm not going to go through each paper because that's just torture, and you got to know your learners, right? And this was an interesting paper where they actually followed around who they thought were good ED educators, and they said, well, what are these guys doing that we can pass on to everybody else? If you guys want to read this paper, it's a really good paper. The title says a lot. I think a lot of it is instinct, but I think the point of this talk is how we pass on this instinct to all of you, and then you can pass that on to everybody else to be great educators within the ED. And then the last paper that I'm going to talk about is this paper, which helped us kind of create some of the tips we're going to give to you in this lecture. This is also focused just on bedside teaching, so bringing it to the actual bedside, and the challenges involved in that, and some of the ways you can optimize your bedside teaching in the ED. These are all in our sources, so you can read these papers to get a kind of supplement what we talk about here today. And it's important that when you walk into a shift that you're ready to teach, because if you're going to walk into a shift and you know it's going to be a busy shift, like a lot of times they are, and you say, all right, I'm just going to get through the shift so I can get home, you're not going to teach well that shift. You have to walk into that shift saying, I'm going to teach the residents. I'm going to teach the students today, and they're going to learn something from me. And either that's just a mindset, but also even preparing teaching points for various presentations, as having them in your mind, having them written down in a book, on your phone, whatever it is that you need. And once you're in your shift, you have to know your environment. You have to know when it is the right time to teach certain things. In the middle of a resuscitation, it's probably not the best time to pontificate on the pathophysiology of what's happening to your patient. Resuscitations are great teaching moments, but in certain ways, it's not the time where you're going to sit there and discuss everything at length. Also, see who's around you. Is it patients? Is it family? You can discuss things in front of patients, but you might not be sitting there discussing the STDs that the patient might have in front of the husband who's standing right there saying, I don't know about that, or so on and so forth. And you have to know your learner, right? Every learner wants something different, right? The medical student is going to be very different than your senior resident. If you're discussing a patient with CHF, your medical student might need to know the pathophysiology. Your first-year resident might need to know interventions like BiPAP, nitro, pros and cons of Lasix. Whereas your senior resident, you might grab the ultrasound and say, hey, let's look at how you measure diastolic function on the ultrasound, because they know all that other stuff. They don't need a lecture on the pathophysiology or how to treat pulmonary edema. So knowing your learner and how to teach them is really important, and knowing everything around that environment. And not only knowing your learner, but preparing your learner. And that's in two ways. You walk into the shift and you tell that resident, your student, like, you're going to learn today. We're going to learn whatever it is going to learn. Or you say, what do you want to learn today? What are you going to focus on today? What's your focus today? And then the other step is when you're teaching your learner, you say to them, I'm going to teach you now. What are you thinking when a resident is presenting to you? You're thinking about the patient in 2. You're wondering why that guy's still there. You're wondering why that person looks like they're about to urinate on the floor. You're wondering all these different things. And your resident's talking to you, and your mind is kind of all these different places. Your resident is probably in 17 other places. They might be thinking about the Game of Thrones episode from last night. Who knows, right? And so by you saying to the learner, I'm going to teach you now, a lot of times what that does is that focuses them and says, hey, I know I'm going to learn something right now. I better start putting my brain into attention mode and not just what else am I going to do now mode.
So where we're going to go through is some actual methods that we actually have been taught ourselves through various wonderful people that I actually will just rely on when I'm feeling a little overwhelmed and a resident's talking to me and I'm like, okay, I need to teach now. This is one of my favorites. It's called SPIT. Serious, probable, interesting, and then what's treatable. It's a great method for a junior resident. It makes them start going through differentials. It makes them start going through the treatment. And they're very aware when you're going through all these questions with them, or at least should be aware that they're being taught. I do think that to emphasize, I always try to say, let's do some teaching, let's talk through this and try to learn something, because I have spent 30 minutes going through the pathophys of why we give aspirin, and at the end of the shift we say, what did you learn today? And they say, nothing. What? I don't know. Look at me, blink, blink. So, it's very important to reiterate this. One of my favorite methods, because this is how we were trained, is using rounds. And I try not to do it spontaneously. It can be very embarrassing for the team. I actually try to pick 2 cases before we start rounding. And I actually will pick possibly a case, most of the time a case that we've actually done some teaching. So the resident who's presenting the case knows the answers, and they don't feel put on the spot. So it becomes a team learning session and not me, questioning a resident in front of the whole entire team. And sometimes it's fun because then the resident will actually turn and teach the team what we talked about already. I try to pick 2 cases that had the most value, maybe something the resident and I looked up or learned together or had to figure out together. Try not to pick all the cases, because then you're on rounds for 7 hours and then everyone's really mad at you. But if I can pick out a couple of cases to teach on, the residents give us good feedback. That was really interesting. I really enjoyed that. We actually got to talk about all the different options, what we should do. And I don't try to do it in what we call the pimping, because I find that makes my residents very anxious. So, I ask the group, and they're actually really good about trying to answer the questions. We've made it a very non-stressful environment. So that's a great way, because you've got to do sign out. So you're already set up to do teaching. And this is the other one, the 1-minute preceptor. This is a good method for your junior to senior residents, because you have to get a commitment out of them. I find that the transition between your junior and seniors is getting them to commit to a diagnosis. They give you great history, a great physical, even a great differential, but then I want them to commit. Okay, so what are you going to do? And I'm like, okay, so we're going to do some preceptorship. I'm going to precept you on this case. So then they also understand that they're learning how to progress to a senior level of thinking and management. And then I ask them, what's the evidence behind their decision? And what's the general principle? What did you use to come to this decision? It's very important to reinforce this. That was great. Or this is what we're looking for. Or these are the 5 signs that you should see. And then I actually, if there's any omissions or any kind of errors that they make, you want to give them guidance. And guidance is just how that could have happened, why you might have been misled, or don't forget to think about this when you see this. But this is a hard teaching method, because they don't realize they're being taught during this. You're not going through studies. You're not going through evidence-based medicine. They don't realize they're being taught a higher level of thinking and approaching the patient when they're transitioning from a junior to senior resident. So I make a point that it's now time for you to commit and act like this is your patient and I'm not here. And this is a big transition they don't even realize they're making half the time.
Bring it to the bedside. That is a great way, and it actually will save you a little bit of time without you realizing it. You're going to see that patient anyway. Why not bring the resident or the learner with you to the bedside and do some great educating right there on the spot? First of all, just your interactions with that patient, you're modeling for them how to interact with the patient. You can go over physical exam findings. And not only that, the patients will actually appreciate it. I know, maybe you think that the patient doesn't want to hear you talking about it. Maybe the patient doesn't want to hear somebody doesn't know all the answers who's taking care of them. But they've actually found that patients appreciate when they're involved in their care. They become part of the care team of themselves. And they can interact with you. They could help fill in gaps that maybe you don't have or your learner didn't have. And there's a lot of opportunity here to do some great teaching of the resident along at the patient bedside. And this one takes a little bit of extra time, but I think you can usually find it even in your busy shifts. And that's working to find an answer. And the saying goes, give a man a fish, he'll eat for a day. Teach a man to fish, he'll eat for a lifetime. And that's kind of what you're passing along to. You're not only giving the teaching point on whatever it is you're trying to learn, but you're giving the learner an opportunity to learn how to figure out answers on their own. So whether it's learning how to look up stuff on the internet or whatever sources you have, and obviously if they come back to you with Wikipedia, that's not always the best result. But as an example, a lot of times the resident will come up to me and be like, oh, I think this person has cellulitis. Let's give some antibiotics. And I will just stare at them and say, that's a great idea. What antibiotics do you want to give? And, they might say, vancomycin and Zosyn. And I'll slap them in the face because that's not the right answer. And I'll say, let's figure out this answer together. So somebody's already thought about this. Somebody knows what antibiotics to give. Let's go and look it up. Let's go find the IDSA guidelines on skin and soft tissue infections, and let's figure it out. Or a lot of times if I'm super bogged down, I might say to them, well, hey, why don't you go look up the answer to this? Or why don't you go find the IDSA guidelines and let me know what you find and let me know what you want to do about this. And then it puts it in their hands, and they get learning out of it, but they also get the skill of the learning as well. Now for the really busy shifts, sometimes you just don't have time to sit down and talk about anything. You're getting killed, right? And that doesn't mean that your teaching moment is gone. You still have an opportunity for your teaching moment. And you can email them. So for the example of the cellulitis, you don't have time. You say, all right, just give the patient a first generation cephalosporin. We'll talk about this later. You email them the IDSA guidelines and maybe a teaching point with that. But then, with your residents, you might need to text them that you emailed them. So make sure you do that as well. I emailed you some information about that you might need to look up, later. So check that out. And that's a really good opportunity to be able to, and it doesn't have to be a paper. It could just be like, hey, that patient, we saw, maybe next time you could do this, or this.
One of my colleagues does that method, and the residents always say, Dr. So-and-so always teaches us after our shifts. We often get emails from him with an article or teaching points about this really hard case we had. And it's interesting because it's written down, like it shows up in their inbox. It might take them a week to look at it, but it's there, and they actually realize that they're being taught. It's that same thing, someone's actually teaching me. My favorite is when the residents bring me a new study or want to do something or not do something based on some new studies. And this is not new, but there's, I'm probably going to date myself, but when we started doing the 6-hour head CTs to rule out the subarachnoid, all my residents were so excited. I don't have to do LPs anymore. So it was like, we really need to go through the evidence. You need to bring me the paper, and we really need to talk about this in the emergency room because they listen to all these great podcasts. They have a lot of great ideas. It's a lot of things that they want to change, and they want to change it that day, that hour, that minute on this patient. And you're like, oh, what are you talking about? And it's really important to teach them how to interpret the studies. Is this a valid, do you have a big enough sample size? What's your statistical power? Is this a good idea for our population? Where was this study done? If it's done in Scandinavia, it might not work in my population in Baltimore. So you really need to work with them to how to interpret it. It sounds really sexy, and it's a great idea, but let's really make sure before we start change everything, they're all very fast adapters, that they can sit down and go through the study with me. I know that you just haven't read the abstract. Now this is actually what we did in our shop. PD went and gathered, which I thought was fascinating, information from the residents. How do you want us to teach you? When are you going to perceive that we're teaching you? So this was the feedback that we got from our residents on this is what we want from you guys. So as Dr. Josh was saying, identify the teaching goals at the beginning of the shift. Sit down and say, what are we going to learn today? What do you need to work on? What scares you? One resident said, I don't like dizzy patients. Okay, we're going to see every dizzy patient in the ER today. And, go through the differential with them so you feel more comfortable. But if you identify those teaching goals and you focus on them with the resident throughout the shift, that, they really do recognize that. And again, as we said, go to the bedside. I find this actually fascinating. I thought the residents were like, get out of the room. I've got this. But they really do like us coming to the bedside and talking to the patients with them. And if there's good physical exam findings, they want us to come get them or be a part of that. They don't want to hear about it. They don't want to see pictures on our phones. They want to see the patient. And then discuss the differential diagnosis. I think that they find in the busy emergency rooms that they give us a really good history and physical, and we like what we hear. And even though they're probably right spot on, we don't make them go outside the box. We don't make them think outside the box. Change the case, change the vital signs, change the history of the patient. Say, well, what if this? What if that? And start running a differential with them so they're prepared next time that same patient shows up with a bit of a different history. And again, the evidence behind decisions. This is hard because you really need to know the evidence yourself. But that's one of the things I look it up with my residents. What's the evidence behind this? You know, we've had a big talk recently about the evidence behind ACLS. There's not a lot of evidence. But, you know, it's good to all talk about that and be honest and say this is what we do. We really don't know why. It's kind of up there with voodoo and hocus pocus. Sometimes it works, but, you know, it's to have an honest conversation about why we do things, and sometimes we don't actually have the evidence when we're doing them. And then debriefing after critical care patients. Does anyone do this? Do you do it with the whole team or just the residents? The whole team. I actually find the whole team is valuable because your nurses and sometimes your techs give you very valuable information about what's happening with that patient, about what they saw, about even how the whole entire resuscitation was run, but going through what we thought was happening, learning from it. And I think it also makes the team walk out feeling like they just went through the whole differential. How do we get from A to B on this patient who came in that we had absolutely no information? That's still a John Doe in our computer. Like we don't know anything about them. And then there's a faculty medical minute. How many guys do medical minutes in your emergency rooms or in your departments? So we did this where we trained the 4th year, had to come up with a medical minute, and we torture our residents at my facility now. And they do a medical minute every day before we start our 7 a.m. shift. They would really like it if the faculty did that. So we're encouraging our faculty to come in. We're not requiring it, but to come in and give a talk. I saw a case yesterday for 1 minute, or I saw it last week, and this is the evidence behind decisions that were made. This is a great article that pertained to it. I just want to make sure we all go through the management of how to take care of this patient, and even pass out a piece of paper with like the 5 points. So this is all great, but how do you handle this? And so we put this together. This is a very ambitious shift, by the way. But this is actually something I will kind of write out for myself before I go in because I am so easily distracted. And I come in at 7 and all of a sudden it's 1:30 and I haven't taught anyone anything. So I actually try to do this so that I have kind of a plan. Now, like every great emergency department, half of this goes to hell in a handbasket when everything goes down the toilet. But if I get half of it done, or even 1 or 2 of the things done, then I feel like maybe I accomplished something. It also gives me structure. I need some structure when I'm teaching, and I remember, oh, at noon I'm going to do this, then I might actually get it done. So I actually try to do 2 teaching points on rounds, and then again ask your resident to identify what they want to learn that day. And then I try to actually remember to use my methods. Otherwise I won't. And then I try to find my cases that I want to use on rounds before I start rounding at 3 that I want to teach from. And then if I'm really, really ambitious, I try to find an article to email them later on. This actually helps me because I do stick to it if I write out. Now I don't do this every shift. I try probably half my shifts, but I'm really trying to move towards that because I can definitely say there's a very big difference when I do this to when I don't. If I don't walk in with some structure, I don't teach nearly as much. So it's really important to me. It's how I function. It might not be for everybody, but it kind of keeps me on top of my game.
So these are some of the points that we've kind of come up with together and we've learned from the people who have taught us. But the beautiful thing about CORD is everybody's here, and everybody here is probably a relatively good teacher in the emergency department because the fact that you're dedicated, the fact that you're here. So we want to take a few minutes now and hoping that people can talk to the people around them and just discuss for a few minutes what they're doing in their ED for their teaching, what's working for them.
Example is I'm supposed to be a CPC judge right now, and I told my table what my session was about, and one of the other judges looked at me and said, oh, we do a whiteboard. We do a whiteboard with teaching pearls at the end of the day. I was like, that's great. And my residents all think they got taught something. So that was a really great idea. We don't do an RED. Maybe we will. But, you know, just talking to my colleagues, I'm always surprised at what they do that I don't do. So what I'm going to do is I'm going to walk to this end of the room. Just talk to your neighbors. Say, hey, what do you do? And then in about 3 minutes, 4 minutes, we're just going to walk down here and get ideas, probably 5 or 6 ideas from people on how they teach in their emergency room if it's different than anything we presented up here today.
What do you guys think?
want to dance?
Hey, what's up? All right, let's wrap it up.
All right,
so
we're going to start wrapping it up, you guys.
Everybody else is learning in the room. All right.
I'm going to stand back here, and anybody who wants to volunteer, and you don't even have to take the microphone, I'll just repeat it for you if you don't want the microphone. Just raise your hands if anything you want to tell us that you guys do in the ER. You guys don't do anything?
All right,
is that why you're here?
Okay. You want the microphone?
Depending on how busy the shift is, you can go in with the resident and you can scribe for them. And so it kind of takes the burden off of note writing, which is a huge burden for our residents. And you can observe them. You can see what they did well, what they didn't do well, the questions they forgot to ask. You can't do it if you've got 2 residents and a med student all the time, but there are shifts where it's a little bit slower and you can go in with a senior resident, just pound out a bunch of notes and patients, and so that their notes are done, so you have extra time to teach them about the specific cases.
That's a great idea. I think I'm going to start doing that. You don't even have to do it probably the whole shift. You can just say, hey, I'm going to go in with you. That's awesome. Anyone else?
Maybe? This row, anybody?
Yes. Oh. Bueller. Okay, we got somebody over there.
So we have started to try to embrace the Post-it pearls culture. It's an initiative largely led by our more senior residents, and like putting stacks of Post-its next to our attendings' desks and computers and trying to suggest, and then putting them up and actually taking pictures of them at the end of the shift and then tweeting them out on our residency Twitter account and on our residency blog so that residents that were not on that section of the shift can see some of the teaching pearls that were from the previous night. So it's worked a little bit.
I like that. I'm afraid my faculty would use it for other reasons, like pick up my kids at 3. But I think those are great. That's actually a great thing to do.
We have a lot of medical students who have recently become a mandatory clerkship, and faculty were complaining that they were impeding flow. So I actually have the faculty see the patient independently first, and then the student goes in. So orders are done, patient's seen. You already know what the student's going to present, so you can focus them to, like, I want you to get a PE history on this patient, or I want you to get an ACS history on this patient. And the flow gets a lot more neutral.
It probably helps the medical students, too, know that someone's already laid eyes on them. Anyone else going to come back down the middle here? Anybody else?
There are three things we talked about. We talked about the 1 minute teaching pearls where you have kind of a fixed presentation. We also like the whiteboard. Some people do it with stickies. But the other thing I like is with UpToDate, you can pull up the topic that you were talking about and email it to them directly after you saw the patient with that disorder. And since we don't use articles or books as often as UpToDate, it's very convenient.
Great ideas.
So I'm gonna head back up to the front. Anyone else before I make it up front? Oh, hey.
I think your point about making it intentional is really important, because if we don't put our foot down and say we're academic faculty, we're going to teach, this is important, then it all just gets under the bus. And so one of the things we're starting to do more is at 7:45 we get our chief residents, seniors, to take the residents out into just a small trauma room, but off the floor a little bit, where they can do 10 minutes of teaching on anything they want. And the attendings stay back and cover keep the ship going. In part to just say, we really value this is important, go do it. Because if we don't, the whole day happens and there's no real attention there's teaching that happens, but it just gets sort of plowed under. And I also think broadcasting when you are teaching and saying directly to a resident, I'm going to teach you something here. I think that helps a lot, because they're getting more teaching than they think.
They're actually getting studies. They get a lot of teaching. They just don't realize it when they come out of the ER, because it's during the cases, is often in discussion form. So they just don't understand that that's what's happening.
Yeah, kind of following up, you had mentioned around sort of directing it towards what the learner's trying to learn. And I usually tell the residents at the beginning of the shift, not to put you on the spot, but within the first hour of the shift, tell me something that you're looking to learn. And a lot of times that provides opportunities for just-in-time teaching around procedures or things. Like an example would be, a resident saying, I want to try to do a subclavian line today. I haven't gotten a chance to do one of those recently. Before the shift gets real busy, say, okay, let's pull out a kid. Let's talk about the landmarks. Let's do that beforehand, provides that opportunity for teaching, or reviewing the differential for shorter breath or something. So you feel like during the shift, if you have the opportunity to choose which case to teach on, you're directing them towards the cases that they are seeking learning on those points. That's been helpful. And I think it helps with the specific feedback. I say, is there something that you're working on in particular? The residents are all about getting very specific feedback at the end of the shift. So it's a good way to close the loop at the end too.
I'm very mean. I like to change the case. So I'll come up with a differential on my own, and then they'll give me the presentation, and I'll change the case to make a different diagnosis and make them go down that line. They don't like that. They do like it, but they're just like, oh, I thought I knew it, and now you're making me think outside the box. It's now sarcoidosis. But it's good, because it makes them go a whole different direction. And I'm saying, okay, let's do some learning. Let's act like this is something that's not happening, and this is happening.
Or even making them take the case to the next level, because they were like, oh, this person has chest pain. Let's just do some D-dimers, and then what? And then I'm like, so let's say the D-dimers are 0.6, and your cutoff is 0.59. What do you do with that information? And this is a great opportunity. Maybe talk about age-adjusted D-dimers or something along those lines, and you can get that teaching point in. And
why are you giving Plavix to everybody who has chest pain? You really have to do that? Why are you doing that? Well, there's some studies. Let's go talk about it.
So that's some great points from the audience, and I hope everybody can take something away from this. Does anybody have any questions before we finish up?
I just wondered if anybody's using the educational prescription format. I've read about it, I've never used it. Where individual residents are somehow having from shift to shift, and it's shared among faculty somehow, of this resident trying to work on this. Mm-hmm. And so the next faculty member who's working with that resident somehow open something and say, oh, this resident's working on X. Let's focus on that.
That sounds really interesting. For those who didn't hear, it's an educational prescription. So the faculty know what residents are working on, what their kind of, I guess, their weak points are, and can kind of help. And they know, everybody knows who to work on for what. I think in my program it would be very difficult. We have almost 100 residents and a lot of core faculty, so it would be really difficult. I think in a smaller program that's very doable.
What we've done, and we're about 50 residents, is this fortunately does happen, but it happens a lot with residents under remediation. So faculty, and they were emailing the faculty who are working with them to have them work on certain stuff, but it's really only the residents who are under remediation. We're not doing it for our stronger residents, which is that really fair, because even your strongest resident would love to learn and have that focus. But we do it for our residents under remediation.
Any other questions? Well, I hope that you can take some of these teaching points off to the clinical area with you and even disseminate them to your residents and senior residents and teach them these teaching points so we can continue our being great clinical educators in the emergency department. Just a couple of points. Remember the spit. Bringing it to the bedside is really important. Using rounds, the medical minute, and preparing yourself to teach. Preparing your learner, knowing your environment, and just going out and doing it, and then that will make you a much better educator.
And yeah, just a real preview right there, and that's it. You guys are all done. Thank you so much for coming at this hour. It's a beautiful day.